We are gearing up to get started this morning. So we're going to start with the first session with the SNAP sessions. This is something we started a couple years ago. It's been one of my favorite sessions. So a year in review. We're going to be having Doctors Kristen Haller, Suzanne Huffnagel, Amanda Shackle, Jefferson Kyle Dryden, and Sean Weiseneck all speaking for us this morning. Dr. Haller gets to start us off. She's board certified in anesthesiology, critical care, and adult cardiothoracic anesthesiology. She practices with Valley Anesthesia Consultants since 2020. Interests include advanced periop TEE, heart failure, and mechanical circulatory support. She'll be speaking today on cardiac anesthesia. Please join me in welcoming her.
Thanks for the introduction, Ashley. So I'm going to take the next 15 minutes to kind of just go through a brief update on the ESC cardiology guidelines for cardiovascular assessment of patients undergoing non-cardiac surgery. Was updated in 2022. Have no disclosures. So I want to use this time to kind of look forward. The ACC should be releasing their update of the guidelines for us any minute now. So I was kind of hoping it'd be out by the time we were here at this conference so that we could talk about it. But instead, I'm going to focus on one part of the ESC guidelines that I would be surprised not to see echoed in the ACC guidelines when they come out. If you don't want to get yourself bogged down in the whole 100-page guideline, the ACC did put out a really nice key points review of the guidelines that highlight some of the differences in the update from the 2014 guideline. And so I have the link there for you if you want to check that out. A whole table they have in the beginning of the guidelines to illustrate completely new sections, revised sections of the guidelines compared to the 2014 guidelines. Some interesting topics, I think, including assessing frailty as a basis for deciding kind of what your patient risk factors are, as well as a new section on COVID-19. But today I'm going to focus on the expanded guidelines regarding cardiac biomarkers for assessing your non-cardiac surgical patients. So when we're talking about biomarkers, the two that they're looking at are high sensitivity troponin and BMP. We're going to come back and talk about them in a minute and a little more in depth. But is anybody using these as pre-op baselines right now, getting baselines on anybody to kind of risk stratify patients? Okay, my hand's down too because we're not using them yet either. But I think hopefully after this talk, and I think once the ACC guidelines come out, we may be expanding their use. So new flow chart. Every time we get a new guideline, there's a new flow chart, of course. This is going to look pretty familiar, I think, to most of us. You can see, obviously, if your patient's going to go for emergent non-cardiac surgery, you're not going to have time to work them up further. You're just going to go. If it's something time-sensitive, like cancer surgery, something where a substantial delay would potentially harm the patient, you kind of have to make decisions about what you can accomplish in that brief amount of time to optimize them for surgery. But the main bulk of the flow chart and focus is if you have a lot of time and you want to think about how can I optimize this patient to undergo a non-cardiac procedure, what kind of track of pre-op workup do I want to send them down? So everybody's going to get a comprehensive history and physical, basic labs, CBC, BMP. You're going to tell everybody to stop smoking, of course, and then we're going to stratify the patients into either low risk, intermediate risk, or high risk from a patient perspective. So on the right-hand side of the screen there, you're going to have your young patients under 65, no cardiac risk factors. Middle column is going to be your older patients or patients who do have some risk factors, and then the left-hand side is going to be the sickest patients, patients who you know have cardiovascular disease. And then in the red boxes there, this is new from the 2014 guidelines. Instead of just getting an EKG, maybe thinking about an echo, they're recommending with class 1 level of recommendation that we get an EKG and biomarkers on all of those patients in the medium and higher risk categories who are undergoing either intermediate or high risk surgery. And then we can think about getting the biomarkers on younger patients who are over 45, so healthier patients over 45 if they're undergoing a high risk non-cardiac surgery. So to talk a little bit more about the biomarkers, I think most of us are familiar with these two lab results. High sensitivity troponin, marker of cardiomyocyte injury, BNP, marker of cardiac wall stress or maybe overdistension. They lean a little bit more heavily towards recommending the high sensitivity troponin. It has some benefits over BNP. It's widely available. It's pretty cheap. If it's normal, you can pretty much say with certainty your patient hasn't had an MI in the couple of days preceding when the lab was drawn. And we're going to spend the rest of the time kind of talking about this idea that if you get a baseline pre-op level, you can diagnose a PMI or postoperative myocardial injury or infarction as early as post-op day 1. BNP has some advantages as well. If it's elevated, you can kind of pump the brakes on that patient, maybe send them down a further workup track to optimize them before surgery, because an elevated BNP level preoperatively has been shown to be associated with worse outcomes. And then for some of our older patients that you and I are used to seeing come in who don't have great functional capacity, they may have lurking undiagnosed heart failure just because they're not able to participate in strenuous enough activity to unmask their symptoms. So you may catch some patients who don't have a diagnosis of heart failure, who then you can send down a further workup track and optimize to hopefully get them through NCS more safely. So perioperative myocardial infarction or injury, or PMI, is defined as acute cardiomyocyte injury. It can be with or without symptoms, with or without EKG changes, and with or without imaging evidence of acute ischemia, so echo, regional wall motion abnormalities, or that sort of thing. So what that means is, with all of the withouts, you can have somebody with no symptoms, no EKG changes, and no imaging evidence. So how are you going to find it? The only way you're going to notice that they have a PMI is by checking your high sensitivity troponins. This is a nice graphic from the guidelines. This is how they kind of are recommending you investigate your patients for PMI. Before a non-cardiac surgery, if they fall into one of the groups that they're recommending check biomarkers on, you're going to get an EKG, a baseline high sensitivity troponin. They're going to have surgery on post-op day 0, and then you're going to recheck the high sensitivity troponin on post-op day 1, and then again on post-op day 2. So to define or to diagnose PMI in a patient, you're looking for either an increase from the preoperative level to post-op day 1 of greater than the absolute value of the upper limit of normal. It may vary a little bit based on institution, just the lab standards wherever you're practicing. But if it increases more than that absolute value of the upper limit of normal, your patient has defined PMI, and then you can send them down a further workup track post-operatively, assess them, get a repeat EKG, get an echo at this point, and see what's going on. If you didn't happen to get that preoperative high sensitivity troponin value, and you're worried about the patient, maybe the intraoperative course was more complicated, they needed a lot of blood pressure support, something that kind of flags that you're worried this person may have PMI, you can get the high sensitivity troponin value on post-op day 1. If it's 5 times the upper limit of normal, you can just go ahead and say right there that they likely have a PMI. Otherwise, if it's low or low-ish, not super elevated, you can recheck on post-op day 2. Again, if it increases by more than the absolute value of the upper limit of normal, you can diagnose them with a PMI at that point. So you can see pretty early in the post-operative course that there may be some degree of myocardial injury going on in these patients. All that's great, but why do we care? We're just arbitrarily checking some labs, defining some degree of postoperative myocardial injury, but it actually is a pretty big deal. So in that, if you remember from the flow chart, that kind of bottom right segment, the patients who are over 65 who have known cardiovascular disease, up to 15% of them are going to show signs of PMI postoperatively when they're undergoing a high-risk non-cardiac surgery. About 90% of this in the perioperative period is asymptomatic because it either happens during the intraoperative course or immediately afterwards, where they're getting higher doses of analgesics. They may not recognize, chest pain versus surgical pain. And overall, about 10% who develop PMI are going to have a 30-day mortality risk. So it is something that's a big deal. Interestingly, the guidelines don't really go into a whole lot about what you can do once you've recognized it, other than just send them down a more intensive clinical workup. I think that information is coming. It has been 2 years since the ESC released their guidelines, so when the ACC releases theirs, we may get some more information on how to treat these patients post-operatively to try to minimize that mortality risk. And that's really what I wanted to share with you all today, so we can all be on the lookout for the ACC guidelines that should be out any day now. Thanks.
Dr. Holler, thank you for that excellent presentation. As you guys remember with the SNAP sessions, we're going to actually hold all of our questions to the very, very end so you can pick our entire panel's brain. Our next speaker will be Dr. Suzanne Hufnagel. She's a clinical professor of anesthesiology and obstetrics and gynecology at Thomas Jefferson University, where she subspecializes in OB anesthesia. She teaches anesthesia residents, medical students, and student nurse anesthetists daily in the operating room and on the labor and delivery floor. She is the chairperson of the Awards and Honors and the Society's Activities Committee, or Scholarly Activities Committees, and is a member of the Board of Governors for the AOCA. She is also an active member of the Society of OB Anesthesia and Perinatology and the ASA. She will be speaking on OB anesthesia. Please join me in welcoming Dr. Hufnagel.
Good morning. I don't have any disclosures. These are my learning objectives. I'm going to talk about neuraxial dexmedetomidine for C-section. I'm going to talk about intravenous calcium as a uterotonic. And I'm going to talk about dural puncture epidural for C-section. These are three of the newer topics that are in current literature for OB anesthesia. We all know this is dexmedetomidine, and most of us have been using it quite frequently. Dexmedetomidine is a selective alpha-2 adrenergic agonist, and it blocks central sympathetic outflow and decreases presynaptic and postsynaptic release of norepinephrine from the spinal cord neurons. It's very highly protein bound, and there's high placental retention, so that's really good for us because you really don't get much transfer out of the placenta to the fetal side. The sedative, anxiolytic, analgesic, sympatholytic properties all come from stimulation of alpha-2A receptors. Whereas larger doses where you can see hypertension and bradycardia, this is from stimulation of the alpha-2B receptors. And it's been used for adjuncts to spinal and epidural analgesia and anesthesia, but keep in mind, this is not FDA approved for these uses currently. So this study by Liu looked at epidural dexmedetomidine plus ropivacaine for C-section. This was the Journal of Anesthesia in 2023. That's what the journal looks like. And this was a study, was randomized, prospective, double-blind, placebo-controlled study of 184 primes. They were singletons, and they had 4 groups, so 46 patients in each group. And what they looked at was the effect of different doses of epidural dexmedetomidine plus ropivacaine for C-section on the visceral traction reaction, which is a reaction when a surgeon handles pelvic organs or exteriorizes the uterus, which is the bane of our existence. And patients can get nauseous, they can have chest pain, arrhythmias. It's usually mediated by unmyelinated C fibers through the vagus nerve. So the 4 groups were ropivacaine, and they used 0.75% for their epidural C-sections. And then there was 3 other groups, ropivacaine with 0.5 mics per kilo of dex, 0.75 mics per kilo of dex, and 1 mic per kilo of dex along with that ropivacaine. All doses with the dexmedetomidine reduced the visceral traction reaction and shivering. It was highly statistically significant. All doses with the dex minimally increased sedation. Now this study and the next couple I'm going to talk about were out of China, and they felt their patients were really anxious, and this minimal but little bit of sedation really improved their patients' anxiety levels. The dex 0.75 mics per kilo and 1 mic per kilo increased thirst. And everything else that they looked at, APGAR's time to a T5 block, hypotension, bradycardia, nausea and vomiting were all comparable. Then the same authors did another study, and this was in BMC anesthesiology in 2024, and that is the journal. This was, again, a randomized prospective double-blind study. They had 92 singleton patients, and there were two groups here, so 46 patients in each group. They're looking at this time the effect of epidural dexmedetomidine plus ropivacaine for C-section. They're looking at pain scores, sedation, and patient satisfaction. So they had two groups, plain ropivacaine 0.75% and ropivacaine 0.5 mics per kilo of dex. And I think they chose that based on their other study, that they saw the least amount of side effects when you were below the 0.75 mics per kilo. So the dexmedetomidine group minimally increased sedation, as the other study showed, but improved analgesia, and that was statistically significant. There was no difference, though, in patient satisfaction. And then the other things they looked at, APGAR's, hypotension, bradycardia, those were all comparable. What about intrathecal dexmedetomidine for C-section? This, again, was a study out of China, and this was, Li was the author, and they, in BMC anesthesiology in 2020. That's the journal, and what they looked at, this was a randomized prospective double-blind controlled trial where they had 300 primes, they were singletons, and they had three groups, so 100 patients in each group, and what they're looking for here was efficacy and safety of adding intrathecal dexmedetomidine to bupivacaine for C-section. So their three groups were intrathecal bupivacaine 0.75%, which is what we use as well. And then they had a group of bupivacaine, same thing, plus 20 mics of fentanyl. And their third group was bupivacaine with 5 mics of dex. Now, how did they pick that? Well, honestly, I think they picked it empirically. I'm not really sure. There was a study in 2023, which I can't go into everything here because I have a short period of time, but that study demonstrated that it was a dose-finding study, and they were using ropivacaine for their C-sections, but between 3 and 6 mics of dexmedetomidine was an ED50. And as they increased the dose of ropivacaine, the ED50 went down. So here they're using bupivacaine, and it's a different author, but also out of China, 0.75%. So I think they have a kind of an intermediate dose here. So that's a reasonable thing. The dexmedetomidine group showed the longest duration, the fastest onset of sensory and motor block, less shivering, and that was very statistically significant. It also showed the longest time to request for rescue analgesia. These patients had a higher heart rate and a higher MAP as well, and that's compared to both the plain bupivacaine group and the bupivacaine plus fentanyl group. And everything else they looked at was comparable. So in summary, epidural dexmedetomidine in doses of less than 1 mic per kilo plus ropivacaine for C-section decreases that visceral traction reaction and shivering. It minimally increased sedation, which they didn't consider a bad thing, but it may increase thirst and improves analgesia. Now, there was another study that came out in 2021, I believe, and this was combination of C-sections, but lower abdominal surgeries and limb surgery, which also kind of goes along with this and corroborates these findings, where this was dexmedetomidine plus fentanyl, or plus ropivacaine versus fentanyl and ropivacaine. They saw the same thing. That's the journal. It was a meta-analysis of randomized control trials, and they also saw faster onset of sensory block, longer duration of block, and longer time to rescue analgesia. And then finally, intrathecal dexmedetomidine plus bupivacaine for C-section showed a faster onset and longer duration of sensory and motor block, and longer time to rescue analgesia and less shivering. All right, we're going to shift gears to the next thing I want to talk about, which is intravenous calcium as a uterotonic. Postpartum hemorrhage is a leading cause of maternal morbidity and mortality, and the most common cause of postpartum hemorrhage is uteronatony. We have certain uterotonics, including oxytocin, methylorganavine, and prostaglandin F2 alpha, and these two here, unfortunately, are limited by side effects, contraindications, stability. They have to be refrigerated, and they're pretty high costing. There's also misoprostol, which can be used rectally, vaginally, or buccally, which we would never do in someone lying down during a C-section, but for vaginal deliveries they've used it, but it really has questionable therapeutic effect. So what about calcium? It's inexpensive and it's stable at room temperature. And labor, as someone labors and labor increases, they've demonstrated that serum calcium levels do increase as well. And also postpartum hemorrhage severity can be linked to lower levels of ionized calcium. So there's something there. So this was a study, Ansari et al., and it was in Obstetrics and Gynecology 2024. And this was a prospective randomized double-blind superiority trial. They had 120 patients, 2 groups, so 60 in each group. They hypothesized that IV calcium would decrease QBL at C-section in patients that were on oxytocin for labor. And that's a good thing to do because being on prolonged oxytocin is going to put someone at risk for postpartum hemorrhage in the first place. And their mechanism, they felt that calcium will improve uterine contractility. So they had 2 groups. One was given a gram of calcium over 10 minutes at cord clamping. The other one was a placebo given over 10 minutes at cord clamping. The primary analysis was QBL at C-section, but they planned from the start to do a subgroup analysis where they looked at QBL after C-section when they removed non-atonic causes of EBL. These are things like hysterotomy extension, which we have occasionally, arterial bleeding, a T incision, adherent placenta, lyomas, vaginal or cervical lacerations. And I'm honestly surprised, but I guess they probably didn't realize this till they did their analysis, that the primary the primary analysis should have been the subgroup, but you know, you live and you learn. So the results. In the primary analysis, the calcium group had an average of 840 milliliters of blood loss, and the placebo was over 1,000. However, this was the mean QBL reduction was not statistically significant, but there's a trend, 0.08. Then they did a sensitivity analysis where they adjusted for imbalances in the baseline characteristics of the patients like AMA, ethnicity, hypertension, diabetes, asthma. They saw in the calcium group that the mean QBL was average was 250 milliliters lower than the placebo group, so that was statistically significant. Then when they did their planned subgroup analysis, where they removed the non-atonic bleeding, the calcium group had a further reduction of 350 milliliters, and that is statistically significant as well. They also found that postpartum hemorrhage and hematocrit change was lower in the calcium group. Other variables, the uterine tone scores, unfortunately, were not different, but that's pretty subjective based on the obstetrician, if you think that the mechanism is increasing uterine tone. The heart rate was lower in the calcium group, and nothing else changed, phenylephrine doses or MAP or anything. Oxytocin-induced flushing seemed to be higher in the placebo group. Now, there are a couple potential problems. Rapid infusion of calcium can cause hot flashes, bradycardia, hypotension, although when I give calcium, like during a bloodless situation, it tends to increase the blood pressure a little bit, and extravasation can cause tissue injury. So in summary, IV calcium after cord clamping for C-section decreases QBL from uterine atony causes, and because it increases calcium concentration, which can increase uterine contractility. It's inexpensive, it has a very stable shelf life, it doesn't have to be refrigerated, it's well tolerated, and it's a low risk, high reward intervention. Last thing I want to talk about is dural puncture epidural versus standard C-section delivery. Now, we've had this described in this conference already, that what a dural puncture epidural is, performed like a CSE without injection of any medication intrathecally. Advantages of it in labor is it can improve analgesia. It can cause you to be more successful with your epidural because you have confirmatory CSF when you put that spinal needle in. And the reason that analgesia seems to be better is translocation of local from the epidural space into the CSF when you dose up the epidural. And studies have shown faster onset, better sacral spread, less patchy blocks, less local needed, less motor block, and higher patient satisfaction scores. Would these advantages hold if you did this for a C-section? So this study was Sharawi et al., and this was in JAMA Network open in 2023. There's the journal. And it was a randomized prospective double-blind controlled trial. They had 140 singleton patients and 2 groups, so 70 patients in each group. These were all having elective scheduled C-sections. One group was a DPE epidural or a straight epidural placed about 60 minutes before the C-section was to happen, and they were dosed with a low-dose infusion of bupivacaine to get a T10 sensory block, similar to what you would want in labor with labor analgesia. Then 60 minutes later, at the time of C-section, they dosed them with chloroprocaine because they're trying to mimic an urgent or stat C-section to get a T6 block. The primary outcome was time onset, or onset of time to surgical anesthesia. They considered that T6. And then secondary outcomes were the quality of anesthesia, maternal satisfaction, pain score during surgery, opioid consumption, adverse events, and APGAR scores. Results: 66 patients in the epidural group and 70 in the DPE. The primary outcome, again, epidural group was 655 seconds, and the DPE group 422 seconds to surgical anesthesia. This was 3 minutes faster, which was highly statistically significant. You might not think 3 minutes is anything, but when you're waiting there, whether to put someone to sleep or not because the fetal hearts are down, 3 minutes is an eternity. Secondary outcomes: the quality of anesthesia was better in the DPE group, but no difference in anything else. The DPE group did have an increase in umbilical base deficit, but the study was a little bit underpowered to assess for this, and we don't know what that means. So in summary, DPE with epidural extension for C-section shows a faster onset to surgical anesthesia by 3 minutes. It's better quality of anesthesia, probably because of translocation through that dural puncture. And 3 minutes, again, may be enough to avoid a general anesthetic in a stat C-section, but there are some limitations to the study. Epidural extension for C-section, this was only 1 hour. And how many hours is it after you put an epidural in for labor that you need to dose somebody up for a C-section? Now, there was a study, and it's not in publication yet, that was listed in this ANA reference I have at the bottom here, where Dr. Sen from Brigham commented there that they have done porcine studies showing translocation of local through that dural puncture up to 3 hours with a 25 gauge spinal needle. But again, that's only 3 hours, so we just don't know. So the clinical setting of C-section, it may be, as we all know, hours after that. So does this benefit diminish over time? It probably does, but we don't know what that time is. And the study was not powered to detect any increase in post-dural puncture headache. Thank you so much.
Dr. Hofnagel, thank you for that very informative presentation. Our next speaker is going to be Dr. Amanda Schackel. Dr. Schackel is originally from Texas. She recently relocated back to her home state from Nashville, Tennessee, with her husband, 2.5-year-old son, and 6-year-old border collie. She recently joined the faculty at UT San Antonio, where she completed her residency back in 2018. Her academic efforts are focused on teaching medical students and residents with an emphasis on regional, acute pain, and point-of-care ultrasound. She is a proud member of the AOCA and currently serves on the Pro Education Committee and recently co-chaired the AOCA Mid-Year Virtual Conference. Today, she will be speaking on regional anesthesia. Please join me in welcoming Dr. Schackel.
Thank you so much, Dr. Klassen. So today we're going to be looking at some updates in the regional anesthesia world. I don't have any disclosures. So today we're going to review some of the current updates, including evidence for regional blocks for hip fracture patients. We'll review the latest update from the REGAIN trial, and then we're going to also look at perineural versus systemic dexamethasone for block prolongation, and then lastly we're going to look at sternal blocks for cardiac surgery. This is again an outline of our topics. As we move through the presentation, I wanted to point out there'll be a QR code that's located on the top right of this slide. You can use your phone to scan that code and it will take you directly to the article or the regional technique that I'm referencing. So hip fracture patients have been receiving a lot of press in the regional anesthesia realm. Given their high morbidity and mortality in this cohort, there's been a significant effort to optimize analgesia and to identify the best type of anesthetic for these patients. So we're going to begin by looking at analgesia, and then we'll talk about general versus spinal. Historically, fascial AOCA block was preferred. So again, we'll kind of look at the two different block types, the PENG block and then the SIFI. So first, we're going to talk about the suprainguinal fascial AOCA block. This was first described in 2011 by Hubbard, and this approach encourages spread of local anesthetic further cephalad into the iliac fossa. The innervation of the anterior capsule of the hip joint has contributions from the femoral obturator and accessory obturator nerves. The lateral femoral cutaneous just covers the cutaneous innervation of the surgical approach. And by taking a more proximal approach, there's more reliable blockade of the femoral lateral femoral cutaneous. And if you put a significant amount of volume, you can possibly get the obturator nerve. And while there are several approaches, the one that's pictured here is what's referred to as the bow tie. And that's created by the sartorius and internal oblique, or another abdominal wall muscle. The block needle is directed caudally to cranially, and then the local anesthetic is deposited right underneath the fascial AOCA. Next, we have the PENG block, or pericapsular nerve group block, which refers to a fascial plane to cover the articular branches of the femoral obturator and accessory obturator nerves. And as we discussed on the previous slide, these branches provide sensory innervation to the anterior capsule of the hip joint, which is largely responsible for nociception. This approach was first described by Dr. Peng and his colleagues, hence the obvious name, in 2018. Using a curvilinear probe for visualization, your block needle will be directed medially between the psoas tendon and the ilium. And as fluid spreads in that plane, there's displacement of the psoas muscle tendon. So given the targeting of the articular branches with this approach, we know that those branches are important for nociception. One would assume that this is a superior approach for analgesia for hip fracture patients. But what does the recent literature say? So we'll go through that. So here we have a randomized double-blind controlled trial that was published in 2023. This had about 60 elderly patients. They had intertrochanteric and femoral neck fractures. Patients were randomized to either receive a PENG block or a sham block, and then they had a standardized analgesic regimen. The primary outcome was dynamic pain scores 30 minutes after block, with the secondary outcome being 24-hour opioid consumption. And when comparing a PENG block to a sham block, the authors were able to show significant lower dynamic pain scores, and also were able to show lower 24-hour opioid consumption compared to the control group. But here they're comparing it to a sham block. So PENG block obviously provides superior analgesic to systemic analgesic regimens with a modest opioid-sparing effect, but how does the PENG block stack up to our other regional techniques? This was a meta-analysis also published in 2023 that reviewed 6 randomized controlled trials comparing PENG versus a fascial AOCA compartment block, meaning they included both the infrainguinal and the suprainguinal approaches for patients undergoing any type of hip surgery. And they found no difference in the 6, 12, or 24-hour pain scores between the two groups, although they were able to show a significantly less opioid consumption in the PENG group as compared to the fascial AOCA compartment group. But here they're using both the suprainguinal and the infrainguinal approaches. So how does that mean that PENG is superior to SIFI per se? This was the very recent randomized controlled trial that was published in this past June, and this sought to answer that specific question. This was a prospective trial of 80 hip fracture patients, and they were randomly assigned to either receive a PENG or a SIFI block. They had similar volumes of local anesthetic, and the type was the same as well. And the primary outcome, again, here was reduction of dynamic pain scores at 30 minutes following the block. And there was no statistically significant difference between the two groups. So the take-home message here is that hip fracture patients definitely benefit from regional anesthesia. They have lower pain scores and less opioid consumption, but there does not appear to be a statistically significant difference between the different approaches especially when you compare PANG versus SIFI. So if you are able to perform a regional anesthetic to provide superior pain relief for your patients, do the technique that you're most comfortable with. In other news, the management of hip fracture patients, there was a secondary analysis of the large pragmatic randomized control trial for hip fracture patients undergoing spinal versus general that was published this past spring. This is the REGAIN trial, as some of you know, or the regional versus anesthesia for promoting independence after hip fracture. They assessed 1,400 patients at 1 year looking at survival, recovery of ambulation, and new transition to a nursing home. They found no difference in survival, recovery of ambulation, and those that did survive, or new admission to nursing home between those patients that either received a spinal versus a general anesthetic. This is one of the few studies looking at long-term outcomes in these patients, especially when comparing the different type of anesthetic that they received. And what it shows is that decisions around the anesthetic type should be individualized and not preferring one type or another in anticipation of an improved outcome. Now we will move from hip fracture patients to other hot topics from this past year. We're going to look at perineural versus systemic dexamethasone and then the impact of parasternal blocks for post-op analgesia following cardiac surgery. This study was published in June 2023. It was a small study conducted on 16 healthy volunteers. The volunteers received bilateral isolated ulnar nerve blocks with bupivacaine, and they did it over the course of 2 days. On the first day, they received perineural dexamethasone in one arm and then saline in the other arm, which is to serve as the control. And then on the second day, they received, in addition to the bupivacaine, saline in one arm and then lidocaine in the other arm. The primary outcome was the duration of sensory nerve block, which they assessed through temperature discrimination. And when they noted when given perineurally, dexamethasone increased the block duration by about an hour. Systemic administration was similar to placebo, and then interestingly, adding lidocaine to the bupivacaine actually decreased the block duration by 189 minutes. So if you're going to use dexamethasone to increase your block duration, it appears to be best to add it perineurally. And then this was an infographic that came out shortly after that study was published, and it basically reflects the same information that we just discussed, and then added a couple meta-analysis at the top where they also looked at perineural dexamethasone and were able to show it to be superior than systemic for block prolongation. All right, and lastly, we're going to look at parasternal blocks. It's a newer regional anesthesia technique that provides analgesia to the medial anterior chest wall. Obviously, sensory input to the chest wall here is transmitted by intercostal nerves, and these run between these two planes. There's two techniques that have been described. There's the transversus thoracic plane block, and that involves depositing local anesthetic underneath the intercostal muscle and above the transversus thoracic muscle, which is a muscle that runs longitudinally very close to the sternum. And then the pectointercostal fascial plane block, which is a more superficial block, is where local is deposited above the intercostal muscle but underneath the pectoralis major muscle. And that's what I have pictured here. The transversus thoracic block is efficacious and has been shown to be efficacious, but the plane is a little bit harder to identify and a little harder to see in patients, and also carries a higher risk of pneumothorax and damage to vascular structures in the area, and namely the important structure being the left internal mammary artery. The pectointercostal plane block is technically less challenging, and it has been shown to be comparable in analgesic efficacy. So while only recently described, the promise of decreased pulmonary morbidity and the decreased need for large amounts of opioids have elevated the popularity of these techniques in a short time. And so here we have a study from 2023 that evaluated the effect of parasternal blocks. Here it's specifically that pectointercostal fascial plane block that I mentioned on the previous slide. And they looked at time to extubation in patients undergoing cardiac surgery. This was a single center randomized controlled trial of about 50 patients, and they were undergoing elective open heart surgery. Patients were randomized to either receive the block with ropivacaine plus dexamethasone or saline as the control, and they were blocked on both sides. The primary outcome was time to extubation. Secondary outcome looked at opioid consumption during surgery. And what they found was that patients that received the parasternal block with the actual local anesthetic had decreased time to extubation, less opioid consumption during surgery, had lower pain scores while coughing. And so what this shows is that adding this technique to other aspects of an enhanced recovery program may be beneficial in improving analgesia and reducing opioid consumption for this patient population. That's all I have from the world of regional anesthesia. My email is here. Please feel to contact me if you have any questions. Thank you.
Dr. Schockel, thank you for that excellent presentation. Our next presenter is Dr. J. Kyle Dryden. He's an anesthesiologist with subspecialty training in critical care medicine. He currently contributes the bulk of his expertise within the cardiovascular intensive care unit of the Richard M. Ross Heart Hospital, along with coverage within both the Arthur G. James Cancer Hospital and University Hospital Surgical Critical Care Units at The Ohio State University Wexner Medical Center, managing patients with challenging pathologies as part of a multidisciplinary team. Additionally, he serves as a member of the neuroanesthesia cohort, providing intraoperative coverage for complex surgical cases, including those for neuromovement disorders, neurovascular emergencies, malignant tumor resection of the spine, skull base, and brain. Of late, Dr. Dryden has discovered renewed enthusiasm for creative writing, leading to 2 publications in anesthesiology of his work. His pursuit in the marriage of medical science and art, rather than its contrasting juxtaposition, is one he looks forward to delving into more robustly in the future. He will be speaking on critical care anesthesiology. Please join me in welcoming Dr. Dryden.
Good morning. Thanks for having me. The AOCA gave me the task of selecting what articles I felt were most important in critical care, which was no small task. I've tried to cram a bunch of heavy hitters, or at least what I thought were the heavy hitters, into that. Hopefully this format works out. If not, I'm sure someone will let me know. I have no disclosures. With the formalities out of the way, we can begin where we usually do, and that's with airway and breathing, as they always come first. Post-op reintubation, relatively uncommon, does lend to significant morbidity and mortality, as you all know. None of us enjoy that PACU call that your patient isn't doing well. Here, Pedinuzzo compiled a meta-analysis of 33 studies over 11,000 patients, in it they found that non-invasive ventilation significantly improved rates of reintubation in post-surgical patients, whereas CPAP and high-flow nasal oxygen did not. They also showed improvement in ICU length of stay, hospital length of stay, as well as mortalities in both ICU and the hospital, as well as long-term. Decreased risk of nosocomial pneumonia, and also they found that this was not more uncomfortable than any of the other modalities. You might think, didn't we already know this? Well, what's different is that these data were for patients receiving therapeutic rather than prophylactic non-invasive ventilation. Most of the guidelines by the societies suggest that for post-extubation respiratory failure that you avoid non-invasive techniques and go right to reintubation. But these data show that especially in the post-surgical population where atelectasis is the most likely culprit, that proceeding with a non-invasive strategy may be beneficial. If you do need to intubate these patients, you should strongly consider video laryngoscopy. Araujo, in a meta-analysis looking at 14 randomized controlled trials, 4,000 patients comparing the efficacy of video laryngoscopy in critically ill patients, showed better visualization, as you can see there. Fewer esophageal intubations, less aspiration, all to a degree of statistical significance. However, there are no incidents in that of dental injury, cardiac arrest, or mortality. After deciding on intubation technique, you have to consider what drugs you're going to use to achieve that intubation. Kuroki in critical care this year shed some light on this with a Bayesian analysis, including around 3,000 patients from 7 trials comparing etomidate versus ketamine. By way of their fancy statistical gymnastics that they did, they claimed an 83.2% survival benefit for those in the ketamine group versus the etomidate group. There's a brand new paper by Kunal Karamchandani of UT Southwestern, came out 2 weeks ago, so it's not included here, where he specifically looks at and gives graded recommendations for this quote-unquote physiological difficult airway. I encourage you to take a look at that. It's a Delphi study, so it's based on surveys internationally, and it has AOCA consensus statements. Moving into ARDS, there's a New Year's gift here from the American Thoracic Society, providing some updated guidelines. The European Society also gave updated guidelines in 2023. We'll be globally centric today and just look at those from the US. First, we have the don'ts. You don't want to do prolonged recruitment maneuvers anymore, and they still want you to avoid high-frequency oscillatory ventilation. Things that they always want you to do: continue with those lung protective strategies as you have since the ARMA trial and the ARDSNet back in the year 2000. Also, strongly recommend prone positioning in the moderate to severe groups with PDF ratios less than 200. And then they have some conditional recommendations. We'll look at those individually here. First, since the DEXA-ARDS trial that came out in the Lancet in 2020, steroids are back on the table for early ARDS, particularly prior to 14 days. After 14 days, you have worse outcomes. The ATS statement doesn't give any recommendations on what steroid regimen to use, but they do recommend using them early rather than later. They again recommend ECMO for severe cases after you've exhausted all other options. And then if you are an ECMO-capable center, to cannulate there and transfer to a high-volume center if you're not one yourself. Neuromuscular blockers are back on the table again. They've kind of been on and off again throughout the years as far as they go. Having the caveat of known weakness in these patients, and again, they should be given sooner rather than later, within 48 hours. After 48 hours, worse outcomes. More beneficial than heavy sedation, and most beneficial also in patients who have ventilator dyssynchrony. Again, they recommend high PEEP in moderate to severe ARDS. Again, PFF ratio is less than 200. They don't give that set Goldilocks number. They just say balance that between your risk of barotrauma and the hemodynamic sequela of high PEEP. So in summary, what's new? Use steroids early. Consider ECMO in the appropriate populations. Use neuromuscular blockers in the severe cases. High PEEP without recruitment maneuvers, and do not do prolonged lung recruitment maneuvers in these patients. Unchanged things, as you know, lung protective ventilation strategy, target that 4 to 8 mils per kg number. Keep your plateaus below 30. Make sure you're proning these patients in even moderate to severe ARDS for greater than 12 hours. Don't use high frequency oscillatory ventilation. After airway and breathing, we have circulation, as is the convention. In this case, extracorporeal variety. Theo in the ACLS shock trial last fall randomized 400-ish patients looking at cardiogenic shock due to myocardial infarction, VA ECMO cannulated prior to coronary revascularization. Primary outcome being death at day 30. While things looked good initially, you can see from the Kaplan-Meier curve here that you're just as likely to die with ECMO or without. Looking at their secondary outcomes, again, no benefit. And as one would expect when trying to hurriedly put a large piece of plastic in a blood vessel, from a safety perspective, more need for vascular intervention and more bleeding. Here's our subgroup analysis, no difference. Severin looked at 160 patients of out-of-hospital cardiac arrest. These were randomized to ECLS versus traditional ACLS, with the primary endpoint being survival with a favorable neurological outcome. Here they found similar survival across both groups, although the gross number was higher in the extracorporeal group. This was not statistically significant. Same at 90 days, or 180 days, sorry. But the good news is that the numbers were the same. If you made it 30, you were likely to make it 180. Somehow they got one more person in the conventional group along the way. I don't know how that worked out. But conclusions you can see here: patients with refractory out-of-hospital cardiac arrest, no survival benefit with good neurological outcomes at day 30 versus ECMO versus not. So not a great year for ECMO. More with circulation, in this case mouth circulation or sepsis and resuscitation. Since Paul Merrick's study on this metabolic cocktail in 2017, there's been a huge interest in trying to replicate those results. 7 trials, the citrus, the vitamins, Ivictus, oranges, actis, attest. In the Victus trial, none have been successful in doing so. Maybe we should look at those components individually. Here, Vine took patients from 2 previous studies with the use of thiamine in septic shock. The patients in both studies had the same thiamine regimen of 200 milligrams BID for 7 days. What they found was you're more likely to be alive and discharged from the hospital, especially in those with a baseline thiamine deficiency, than those with not. Also less likely to be on renal replacement therapy. And it's held especially true for those patients who had a thiamine deficit at baseline. More on supplemental medications that we can give in sepsis. GUA has a retrospective cohort from a database of 50,000 patients going back to 2008, looking at all-cause ICU mortality at 28 days and those who received magnesium versus those who didn't. Kaplan-Meier curve here illustrates the benefit of magnesium supplementation with improved probability of survival in those patients. Also improved ICU and hospital mortality, as well as less renal replacement therapy and increased lengths of stay, or decreased lengths of stay. What's really interesting about these data is that this holds true for patients who aren't hypomagnesiemic at baseline. So even if you have normal magnesium, it's still beneficial to receive even more. Continue to believe magnesium is one of the few drugs that works, and this supports my bias. What else can we give these patients? Ibarra Estrada looked at 91 patients using vasopressor need and ventilator days, length of stay mortality, in septic patients receiving methylene blue. They were each given 100 milligrams over 6 hours, times 3 days versus placebo. You can see from this graph, the significant effect methylene blue had on the ability to wean norepinephrine. Also, those in the methylene blue group had a shorter duration of vasopressor need, and here from the Kaplan-Meier, they're more likely to be off vasopressors at all time points. Additionally, the vasopressor discontinuation, there was improvement in fluid balance, both ICU and hospital length of stay, but not mortality. And following this, Fernando published a nice review of methylene blue and septic shock in July of this year, included 6 randomized controlled trials looking at short-term mortality, arterial blood pressure, the parameters that you can see here, and provided the first graded evidence, albeit that of low certainty for methylene blue, that it may reduce short-term mortality in sepsis. Methylene blue typically used for vasoplegic and refractory shock, but it may be prudent to employ its use earlier rather than waiting. No ICU talk would be complete without steroids, so lucky for us, SCCM provided an update on their usage in critically ill patients this year. As far as sepsis goes, they suggest administration in septic shock, so it's back on the table. It's been another on-again, off-again thing, but they do not recommend the high-dose pulse steroids that had been used in the past. They don't give a specific regimen, but list a few common ones, and do mention that the addition of mineralocorticoid, particularly fludrocortisone, is likely beneficial. ARDS we already touched upon, but the SCCM statement is congruent with that of ATS. In recommending in moderate to severe ARDS employing steroids early. For community-acquired pneumonia, they recommend steroids in those hospitalized patients with severe bacterial pneumonia with a 5 to 7 day course. Again, they don't provide any specific regimens for these patients, but they do give a table within their guidelines with some common regimens. Right, this is not primary research, but interesting paper in the British Journal of Anesthesia looking at the mechanics of the addition of mineralocorticoid to glucocorticoids in septic patients and critically ill patients. Just mention it here for those of you looking for a way to cure your insomnia. But it's interesting nonetheless. All right, what about beta blockers? It's a little bit counterintuitive in shock. The theory is that you have this mitigation of the sympathetic overstimulation that can improve myocardial efficiency, lengthen diastolic filling time, increase coronary perfusion, decrease myocardial oxygen demand. So in the STRESS-L study, the investigators, they looked at an ultra-short-acting beta blocker, Landiolol, which is not commercially available in the US, akin to Esmolol, faster onset, more beta-1 selective, and less hypotension with it reportedly, targeting a heart rate between 80 and 94 as a means to reduce organ dysfunction, primary outcome being a decrease in SOFA scores. They only achieved about 126 patients, which was less than half of their goal before the study was terminated due to a signal of unlikely benefit, potential harm. You can see here no difference in SOFA scores or 28-day mortalities, unlikely a signal toward increased mortality at day 90. Also some of that no-duh data, like more more norepinephrine need, lower MAP, lower heart rate, which is what they were shooting for. It's a throwback to Morelli's trial back a decade ago, which wasn't really well adopted, showed some benefit using esmolol in septic shock. Hasn't been well replicated in randomized controlled trials. What we know is if you give these patients beta blockers early, they do worse, so it's kind of finding that time frame where it may be beneficial. The classic trial from the New England Journal of 22 showed no difference in liberal versus restrictive fluid strategy in sepsis, but both those cohorts received about 3 liters prior to randomization. So here the Clovers trial tried to expound upon that data using early vasopressor use versus liberal fluid management. Volume could be given based on set criteria of hemodynamic parameters or lactate. The liberal mandated 2 liters up front as a bolus. Altogether, 1,500 patients. Restrictive strategy received about 1.8 liters less than with the initial resuscitation. However, no difference in mortality or any of the other outcomes measures. That is, restrictive was not better or worse. It probably tells us what we already know, that the use of these static markers of fluid management are not appropriate. We should be using those dynamic ones of fluid responsiveness. So if your patient's fluid responsive, give fluid. If they're not, don't. Next we have Gabarret from Critical Care this year. Slightly different look at the ongoing continuous crystalloid colloid debate, specifically looking at tissue perfusion, sort of a novel approach. Patients given 500 milliliters normal saline bolus versus 100 mils of 20% albumin at time 0. Tissue perfusion was then evaluated as per capillary refill time at hour 1. You could give additional boluses from hour 1 to hour 4. And then remeasure the capillary refill time as well as serum lactate. You see here at hour 1, there was improvement in capillary refill time in the albumin group versus the saline group. At hour 4, vasopressor needs and hemodynamic markers were the same. However, capillary refill time in the albumin capillary refill time was faster in the albumin group and lactate was better. What does this mean clinically? Probably not a lot for those albumin stands like myself. When the pharmacist tells you can't have albumin, you can talk about this study. What else can we give these patients? Blood, of course. Study out of the UK this year, the Cryostat 2 trial. Cryostat 1 was just a feasibility trial. So Cryostat 2, they looked at using empiric cryoprecipitate in bleeding trauma patients. 1,500 patients. No improvement in mortality at day 28. And what's really interesting about these data is that for penetrating trauma, it actually showed worse outcomes in those patients. So again, keep doing what I hope you're all doing in your bleeding trauma patients, using TEG or ROTEM as a guide for your transfusion therapies. More with blood, you had the MINT trial that came out this year, or into last year, comparing liberal versus restrictive transfusion strategy and mortality in patients with myocardial infarction. The restrictive strategy could transfuse at hemoglobin of 8, but highly encouraged at 7, or with any anginal symptoms, whereas the liberal strategy had a threshold of 10. Well, they find no difference in the primary endpoints of death or myocardial infarction in these patients. You're probably getting hungry right now, so we'll move to nutrition and glycemic control, their last step. SCCM continued with the guidelines galore this year. Just briefly, 180 is the new target point. Some are still using 200. The old guidelines were 150. Whatever protocol your hospital institutes, make sure it's one that avoids hypoglycemia. Still don't push for those lower numbers like we originally did with Vandenberg's study. So don't push to go below 140. Using a higher threshold in those patients with baseline elevated hemoglobin A1Cs is not ready for mainstream. There's some observational data that those patients probably do better with a higher goal level. But again, that's not been quantified with prospective trials yet. Should no longer be using sub-Q infusions in any of these patients. Previously, they said that you could, but now they say you always use infusions in the ICU. And we should be checking more frequently than we probably do, at least every hour or more. And the goal there is, again, is to avoid instability in glucose as well as hypoglycemia. So quick summary, again, like we said, avoid or shoot for, start when it's above 180, avoid hypoglycemia. The goal is 140 to 200. Personalized goals are probably going to happen at some point, and check frequently. Lastly, this statement, practice guidelines from the ASA is actually 2 years old, but they reiterated it in an ASA Monitor article in April of this year. What we know is these patients get inappropriately fasted. or increased risk of that when these procedures are supposed to get are delayed. About 20% of these procedures are delayed until the next day, leading to inappropriate fasting, as we said, starvation of these patients, and then in turn worst outcomes. So they proposed the following guidelines, as you can see here. In hospitalized patients undergoing non-GI, non-lung, or airway procedures in the supine position, tube-feeds should be continued up until the time of transfer for those with a secured airway. For those with natural airways and receiving post-pyloric feeds, they can be continued up to 2 hours prior to the procedure. And this is based on all the available data they have. No increase in patient harm, showing a decreased risk in ARDS, pneumonia, and mortality in these patients. Here's a little table where you can go back and see the review. And thank you.
Dr. Dryden, thank you for that wonderful presentation. This is exactly why I like this section. The little internal nerd in me comes out, and I'm super happy with all of these numbers. So our next presenter is Dr. Sean Washik. He is a liver transplant anesthesiologist at Jefferson University Hospital. With a passion for teaching, he dedicates his time to educating and mentoring residents. In his spare time, he enjoys watching his favorite soccer team, the Philadelphia Union. Today, you'll be speaking on liver transplant anesthesiology. Please join me in welcoming Dr. Washik.
All right. So the title of my talk is What's New? Technological Advances in Liver Transplantation. So today we're going to talk about two significant and complex developments in this field as they relate to liver transplant, the use of normothermic machine perfusion and normothermic regional perfusion. Both of these represent an advancement in our ability to save lives through organ transplantation. I have no conflicts of interest. One thing that I think we can all relate to, just a little guide to the operating room. Thankfully at Jefferson our surgeons are pretty good, so generally they're not grumpy and bloody. So why are we going to talk about these things today? So waitlist mortality is the reason. The demand for organs always exceeds the supply, so this often leads to the consequence of patients dying while waiting for a life-saving transplant. So in 2017 specifically, 58%, just so everyone can benefit, this is what I was talking about. So again, waitlist mortality. So in 2017, of the patients listed for liver transplantation, 58% received one, 10% died while waiting for one, and it left an additional 9% waiting for an organ. So how do we increase the supply of organs? And as you can see in this chart here, again, it just furthers my point. The longer someone waits for a liver, obviously the less chance they have for survival. So one of the big ways that we can increase the supply is through DCD donation. So the first liver transplant was a DCD donation. However, it kind of fell by the wayside once brain death was established legally. And the reason being is that because a DCD organ undergoes an additional time of warm ischemia, oftentimes your outcomes when those livers are transplanted are not as good as a deceased brain dead donor. So with your deceased brain dead donor, you're perfusing the organs the entire time during the procurement. So we're going to talk about improved organ preservation techniques. So this is what we hope to accomplish with both of these things. So how do they differ from what's currently being done? Well, the gold standard is currently static cold storage. Before these were kind of pioneered. So the first kidney transplant was actually performed in 1954 by Dr. Joseph Murray, who you can see here. This was between two identical twins. So basically one was in one operating room, the other was in the other, brought the organ from one to the next and transplanted it. So what this did is it basically showed us that we need to find a better way to preserve these organs so that we can make this more widely available to everyone. So the idea of static cold storage was kind of pioneered by Dr. Thomas Starzl, who you can see there in the desk. So he kind of realized by cooling this organ down and putting it on ice and reducing the metabolic needs that these organs will actually, it will help prevent injury during the storage. But what about the fluid that we use? Could we tailor a fluid to better preserve these organs? Well, that's where these guys came in. So the University of Wisconsin solution, which was developed at the University of Wisconsin, was a solution that was designed to preserve and prevent injury during storage. So it was developed by Dr. Fred Belzer and Dr. James Southward, who is a biochemist. So basically in this solution, it contains a sugar to help prevent cellular damage, a starch to maintain oncotic pressure to reduce cellular swelling, glutathione and allopurinol to help prevent reperfusion injury, and adenosine to support cellular energy production. So what about the idea? So we're going to talk about pumps today, right? So when did this come about? So the solution was created in the 1980s, so it had to be sometime after that. Well, actually, Dr. Belzer preserved a kidney on a perfusion pump in 1967 for, I believe it was 19 hours before it was transplanted into a patient, immediately started making urine. However, it wasn't really feasible at the time because of the technology to continue this. And then once, the Wisconsin solution was developed and cold storage was mildly perfected, you could store a kidney or a liver for up to 12 hours and it would do pretty well. But what about the first instance of this? So the first instance of machine perfusion actually dates back to the 1930s, the unlikely pairing of Charles Lindbergh and Dr. Alexis Carrel. So they developed the machine at the Rockefeller Institute in New York that perfused organs outside of a body, and most famously a thyroid gland of a dog for 18 days. All right, so we've talked about some of the limitations. Let's look at the future and where we're going. So normothermic machine perfusion allows for better preservation of donor livers compared to traditional cold storage. And basically what it does is it keeps the organ at body temperature, supplies it with oxygenated blood and nutrients, and you can even treat it with medications if need be. Basically what we're doing is creating a more physiologic environment. But what it also does is provide a real-time assessment of the organ, so we can look at things such as perfusion in the hepatic artery, pulmonary or portal vein, and then we can also look at things like bile production and lactate clearance as well. So what we're doing with viability testing is at times they'll take marginal donors, they'll put the liver on a pump, lactate will start around 16 or so. We see how it does over the next couple of hours. If it plateaus and starts to go down to roughly 1 or 2, usually the organ will be okay. However, if it kind of stays where it's at or increases, generally that liver is discarded and it's not used. But what this allows is you to increase the pool of organs that you're using, and hopefully you're transplanting a better graft. So this pump is actually primed with a buffered electrolyte solution, albumin, 5 units of packed red blood cells, and broad-spectrum antibiotics. There's also the perfusate is also supplemented with a continuous infusion of 4% amino acids, 10% dextrose. And like we said, we can monitor the hemodynamic parameters throughout the entire time that this organ is being perfused. And again, the hope is that with all of this, we increase the number of donors and increase the quality of the graft that we're placing into a patient. So this just kind of shows how the circuit is connected. Pretty routine, basically. I say that, and obviously I have no idea how it works. So we're going to look at one study. So the PROTECT study in 2019 was actually what led to FDA approval. So this was a multi-center randomized control trial aimed to compare this liver pump with traditional cold storage. Basically what it found is there was a lower incidence of early allograft dysfunction compared to those with traditional cold storage. And again, like we said, it also allowed for better organ assessment and just allowed the transplant team to better coordinate everything. But what if we could prevent damage to the liver? So even with this technique, what you have to do is there is some warm ischemic time, then the liver is placed on the pump, and you hope that the organ perks up. So this is where normothermic regional perfusion comes in. Basically what this means is that you have a DCD donor, the patient is taken into the operating room, allowed to expire, you observe the mandatory hands-off period, and then the patient is hooked up to an ECMO circuit. So what you're doing is you're reestablishing circulation, and the organs now have a supply of oxygen and nutrients that they need to possibly heal themselves. But you can also, this creates an uncontrolled situation to a more controlled situation once you're established on that ECMO circuit. So some of the studies that were looked at here were actually in Spain, and basically what they found is a lower incidence of ischemic cholangiopathy. So the whole idea with this technique is to convert a DCD donor to a deceased brain dead donor, which they actually ended up comparing. So in Sweden, what they did is they used a historical cohort of deceased brain dead donors and a group of controlled deceased cardiac donors using normothermic regional perfusion. And basically they found no difference between the two groups. So the whole idea kind of stands that you're converting a DCD donor into a deceased brain dead donor. So where do we go from here? So the whole idea is improved resource utilization. Now the question mark is because this requires a ton of resources to actually accomplish this. So specifically with the normothermic machine perfusion. So you have a perfusionist that travels with the liver the entire time, sits there, monitors everything, makes adjustments if needed. There's usually a surgeon from the company that places the liver onto the pump as well. So it is a lot of additional resources that are needed. In normothermic regional perfusion, generally a cardiac surgeon is there to place the patient onto ECMO. And then, if you're harvesting a liver, then the liver transplant surgeon will then harvest the liver. It's just a lot more people involved. Now, we have to balance this obviously with outcomes. If we're improving outcomes and if we're increasing the amount of grafts that we have, then I do think that this could possibly, be financially viable. The other interesting thing, so a lot of the data for both of these techniques comes from Europe, specifically Italy. Of note, Italy's hands-off period after the patient expires is 20 minutes. So every single DCD donor that they do in Italy goes on to normothermic regional perfusion and then sometimes also on to normothermic machine perfusion. So that's all I have. I hope everyone enjoyed that. Again, I do think that these two techniques will be used in the future. It's just kind of figuring out how to make them more widely available to everyone, so it's not just a couple institutions that are doing this, and then other institutions have poor graphs. Any questions? Thank you.
Dr. Wyshik, thank you for that presentation. And with that, we will open it up to questions. So guys, you have an amazing panel of brilliant minds up here. Please raise your hand if you have a question, and we'll start bringing some microphones around.
Hey guys, thank you so much for all those talks. I wrote down a few questions I had. They're mostly geared towards kind of Dr. Huffnagel and Dr. Shakal. The first was, did they comment anything on the effect of pruritus with the use of dexmedetomidine in the OB world?
About dexamethasone?
No, dexmedetomidine.
I'm sorry, it's hard to hear. What?
Sure. Did they make any comments on the effect on pruritus of the use of dexmedetomidine?
They didn't comment specifically. I think that if it had an effect, it would have been in the outcomes, but it really, I don't know if they looked at it. They didn't comment in the study on it.
Okay, the second question is, I know in the regional world, we've kind of looked at what's the appropriate dose of some of our adjuncts or additives, and some of the research is pointing towards the mere presence of these medications for prolonging the duration. Do you know if the presence, or if they've looked at the dosages of dexmedetomidine or other additives?
Yeah, actually, there's lots of different studies about that, and I do a talk for the residents that encompasses like all the different adjuncts, and that's a whole different talk in and of itself. I focus specifically in this talk on dexamethasone because that's the one that has the most evidence behind it. They have looked at the dose. I can't remember the exact study off the top of my head, but they did do a study where they looked at like 4 milligrams versus 8 milligrams, like 2 milligrams. I think they settled around 4 is sufficient. I don't think you get much more benefit when you go to 8. So I think that's why most of us use 4 milligrams, and that's what they did in that study that I highlighted.
Okay, cool. And the last question is, did they look at comparing DPE to CSE?
Not in the study that I showed. I haven't seen that in the literature at all yet. I think the point there would be CSE for labor and then let that wear off. But that's very interesting. I think that by the time, in that time frame where it was, they did allow that. But if there was an extended period of time after that, it's very interesting. Thinking that translocation of local from the epidural that has a more speedy onset of the epidural level for C-section, the things like what we use in our CSE, the Sufenta, that's gone, the local is gone too. Does that make the whole stay open longer? I don't know. I kind of doubt it, but it's a very interesting question.
One question for Dr. Huffnagel on dexmedetomidine. Do you know if they have any stability studies or studies which suggest any kind of neurotoxicity if you use that on a long term?
Not that I know of. Now, again, those studies are out of China, and it's not approved in this country. I know that clonidine, there's a black box warning about it. That's, I think, more hemodynamics. Now, you would have to make sure that you had a preservative-free form. I have no experience using it here, and we are in an area in Philadelphia where when you use something off-label, and something happens, people jump on it. So I don't know stability studies with it yet, but they seem to have some pretty good literature from those studies in China, and I look forward to more of that because we are really struggling with this this traction response when all of our obstetricians exteriorize the uterus, and we can get through an epidural section, great, baby's out, and then all of a sudden they pull the uterus out, and then it's just awful the rest of the time. And if it helps with that, I'll be one of the first people on the bandwagon to do that. Plus that little bit of sedation is going to help a lot of our patients as well because they're just so anxious and, I mean, asking for something before cord is even clamped. So I think it's really great to look at, but I don't know of any studies saying a lot of the downsides to it yet.
We use a pretty fair amount routinely of clonidine in our pumps for post-stroke central deafferentation pain syndrome and CRPS. It just, it begs the question, is this something that could be on the horizon, a good adjunct for intrathecal use? The problem is knowing whether it would be good for long term. Yeah, obviously you'd have to do toxicity studies, neurotoxicity.
I mean, one other issue with it is it does prolong duration of motor block, so you're going to have people on the labor floor that are going to be there longer depending on the criteria that you have before you can discharge them from the floor.
Another question for Dr. Huffnagel is very popular right now. With DPE, and we've talked about this before a bit, do you think we're at a point of recommending DPE as a routine primary labor analgesic or more situational, such as a TOLAC or a difficult placement, and then you're going to see if you have the return of CSF? Where do you think we stand on DPE as a primary plan?
I haven't embraced it fully because I just can't imagine that we're not going to get an increase in post-dural puncture headaches. And I know most of the studies out there have not shown that. The ones that I looked at here were not really powered to say that. But it also depends on the kind of needle that you use for the spinal. And the smaller the spinal needle and the lower the incidence of post-dural puncture headache, the less the translocation into the intrathecal space. So, is it really working? Is it worth it? I personally don't do it on every single person. I think that back in the day when I was a resident and we started doing CSE, it's great, we're going to use it on everyone. And we kind of did get into this where we used it as a crutch, and then you didn't have the power or the sensitivity in your fingers to know that you were truly in the epidural space. I mean, that's good, that's bad. I would not do DPE on every single patient because, again, the incidence of post-dural puncture headache, I just can't bring myself to do it. But on the few situational instances where I think that it's necessary, confirmation that we are where we are, or a strip looks really, really bad and they're probably going to call a section in an hour, but they haven't done it yet and the patient is uncomfortable, I would consider it. If I'm replacing an epidural because of sacral sparing, I will do it because it's shown some benefit there. I am not on board with every single patient. It also adds a little bit of a cost because you have that spinal needle that you're going to use, and if you weren't with an epidural, and again, that depends on the contract that you had as far as how much it costs to put those needles on your kits too.
Could you comment on ESP block versus parasternal block for open heart?
Yeah, so the questions for ESB block versus the parasternal blocks that I reviewed. Um, ESB block, there's, some conflicting evidence out there of its efficacy for various types of surgery. I would say, looking at cardiac surgery, what you're largely doing is sternotomy. Now, certainly we could talk about like mini mitral surgery where they do a thoracotomy. In that case, if you're doing a thoracotomy or something on the lateral chest wall or something posterior, ESB has been shown to be effective in terms of analgesia. But like I said, there's a little bit of conflicting data out there because the approach to the ESB block, there's some provider variance. So I think if you're considering ESB for a midline sternotomy, you're not going to get enough coverage in the midline area, and that's where these parasternal blocks, because you're literally right off the sternum and blocking those intercostal nerves as they're running through that plane, literally right off the sternum. I think those are going to be superior. Some of the downsides to them, which I didn't mention in the talk, just given the time, obviously it's essentially an intercostal nerve block, so the uptake of local is really quick in that area, so you don't get a large duration of analgesia from these blocks. Best case, even if you add adjuncts like dexamethasone, which I would advocate you do if you do these, would probably be about 12 hours, maybe 14 hours. So I think they need to be utilized with like a goal in mind, whether that's to extubate the patient, in the OR if you're doing a single vessel cabbage off pump, or to extubate them earlier in the ICU. I've actually personally in practice used them as rescue blocks. They can be repeated, and I've done that for patients in the ICU where we do a block and then we come back the next day after it's worn off and we do it again. And that's been able to rescue patients from reintubation and escalating ventilatory support.
I have a non-regional question. So Dr. Dryden, Dr. Washik, kind of a question for both of you guys about methylene blue. And I know Dr. Washik, you didn't talk about methylene blue, but I'm kind of curious about whether you use it in liver transplant. And Dr. Dryden, I feel like methylene blue is something that we use in our CV ICU, but we don't really use it much in the surgical ICU population with septic shock. Are you more likely to reach for that? And since we also have access to angiotensin II, would you pick one over the other initially? And a similar question for Dr. Washik about liver transplantation.
Yeah, so it's been looked at. Methylene blue's been looked at in vasodilatory shock, specifically post-cardiopulmonary bypass. We use it a lot. They use it a lot intraoperatively for that, for refractory shock. I think the pharmacist would prefer you try methylene blue first, now that it's not on national shortage anymore, as it's cheaper. We tend to now use angiotensin II pretty readily in our unit. The earlier data on it, looking at especially patients at risk of right heart failure, increase in angiotensin in those patients, risk of thrombosis was increased, but we haven't really seen that, and the data haven't borne that out. I think that it's something that we should be using earlier rather than waiting for profound shock and looking for something else to do. And like, oh, maybe I'll just throw methylene blue and thiamine and cyanokit and vitamin C and vitamin E and doing all those things at once. So probably before that happens, we should be using it. It's now recommended in sepsis for the new guidelines. There are some older surgeons that have raised some concerns about the incidence of splanchnic vasoconstriction with it and risk of intestinal anastomoses, increased bowel ischemia, but the data doesn't really show that. There's actually some rat data that shows improvement in those surgical lines, and that the actual increased systemic perfusion is going to make your gut flow better anyway. So I think we probably should use it earlier than we do. Which one I would go for, it probably depends on the scenario, what I think is going on. But Ang2 works. The good thing about Ang2 is if it works immediately, and if it doesn't, then try something else.
So the shorter answer is no. I don't use it. But the long answer, so we used to do liver transplants, and it would be very fluid forward. We put a swan in everyone, measuring cardiac output every 20 minutes, seeing if we can increase preload. we found that probably a lot of those patients were just getting way too much fluid. So we've kind of switched now to almost press her early, treat it like almost a normal hepatectomy early on, try and minimize the amount of fluid so we decrease the amount of blood loss, and then you can kind of sort things out after reperfusion. So I use norepi a lot. And the other thing that I'll say is, anecdotally, especially reperfusion on the pumped livers has been incredibly smooth. You're used to epi on reperfusion, all the things ready. And I'm almost treating the hypertension that I caused by doing all that now. So yeah, but I do think I have used it before, but it's in those instances where it's norepi, now we're on vaso. What else can we use to try and sort this out?
We are coming close to our time. I do have one quick question for Dr. Holler, but I'm going to put on a little bit of a different hat. For those of you that don't know, I'm interventional chronic pain, so I vary back and forth between both sides of the curtain. A lot of the ASCs I work at, a lot of the preoperative assessment is done actually by nursing staff, and my anesthesia staff is sadly not always involved. So they don't do risk stratification on the case. Obviously, a block or an epidural stimulator implant is a very low risk case, but they treat everything like it's a high or even interthoracic risk case. So I'm already seeing in my 25-year-olds that they're having to get EKGs. My fear is now with recommendations being to get pre-op cardiac markers. Do you see that being an increased cost burden on the healthcare society in general? And kind of in conjunction with that, are our surgery colleagues going to have to start putting that on their preoperative labs even 2 weeks before surgery?
Yeah, I mean, I think that's a great question. I also make my way out into the ambulatory centers. Sometimes and I'm sure it's a wide variability of how the places are run. I think it definitely can contribute to increased cost if all of a sudden we just put out blanket, everybody needs an EKG because we order an EKG on most people because most people are over 65 who are coming for their nerve stims, that sort of thing. So that's really, I think, an education issue to take to the ambulatory staff. On the surgeon perspective, I do think that with especially BNP, it's going to be interesting because that's sort of the safety net they're looking for, maybe undiagnosed heart failure, maybe the HFpEF patients who are relatively compensated or maybe don't do a whole lot, and you draw their BNP and you find out, oh, they could be optimized better. That's going to take our surgical colleagues to kind of buy in, recognize early, maybe plan to schedule patients with their cardiologist early to tweak things before they're coming. If it's discovered day of, then we're going to have to deal with, are we going to cancel this? Are we going to proceed? I'm interested to see how that goes myself because there weren't really recommendations regarding what to do if you find it, as well as the troponin PMI issue. So now we've identified people who we know are at a higher mortality risk when they have PMI on post-op day 1, 2. But what are we going to do to improve their outcomes?
All right, with that, the moderator has pushed us over time, so I will not ask any more questions. But I want to thank everybody for their questions. I love having interactive sessions like this. Please join me in thanking our incredible panel up here. Like I said, this is one of my absolute favorite sessions.